Okay, so we're on to a couple of concepts now. Before NIH can publish a Notice of Funding Opportunity, the new NOFO word, we have to have a presentation in a public meeting. We always use the open session of council so that council is fully aware of all of the initiatives that we wish to launch. So Rob is going to give a presentation, and we will then invite a discussion from council, and then I will ask for a vote to approve the concept. So Rob Rowley, Program Director in the Division of Genomic Medicine, is going to present the concept on Genomic-Enabled Learning Health Systems, which is an RFA.
Well, thank you, Rudy. And I also wanted to take a second to thank all of ERP for their wonderful input in making this happen. So I'm going to talk today about learning health systems, and this goes back quite a ways, but we think it's taken that amount of time to get genomic information ready for implementation. But this goes back to 2015. The National Academies published a workshop on genomic-enabled learning health systems, which put the point that learning health systems are essential for genomic medicine. And this was followed in 2020 by the NHGRI strategic plan, which a key part of that vision was to enable the virtuous cycle between genomic discoveries and also taking that into health systems. And in 2021, the Genomic Medicine 13 meeting was focused on genome informatics and health systems. And a key finding of that was the need to actually develop interoperable genomic information or to be able to exchange genomic information. And then in 2022, we had Genomic Medicine 14 meeting, which was specifically focused on genomic learning health systems. And a key part of that meeting, or the conclusion of it, was a need for a network to be able to develop best practices and resources for sharing. So we thought it'd be helpful to actually how we're defining a learning health system for this concept. And I think the important point is it's one that where internal data and experience are systematically integrated with external evidence and resulting in knowledge being put into practice. In other ways, is there's evidence-based interventions. How do we make that, bring that into practice? And so the fundamental principle is generalizable knowledge can be captured from every patient and provider encounter. And then how do you use that information to improve not only the way that you're doing things, but to make sure that you adopt the evidence into practice and improve patient outcomes. So there's many examples of learning health systems, whether it's an early introduction of palliative care and end-stage liver disease to prevent readmissions. There's also testing and delabeling patients with penicillin allergies. But then this last one, I'm going to take a little bit more time. It's balanced crystalloids, reduced adverse kidney events, and using that as an example to demonstrate the effectiveness of a learning health system. So balanced crystalloids versus saline, there's always been a long debate, usually between the surgical and medical specialties, of balanced crystalloids or normal saline, which one should you use in critically ill patients. Well, a learning health system actually did evidence, and my intention here is not to debate this evidence, but they found evidence that balanced crystalloids, I hate to admit the surgeons were right, but either way, they found that they had major adverse kidney events at 30 days or less. So that's the evidence-based intervention. Through that virtuous cycle, the next step would be, let's come up with a way to actually use this learning health system and putting into action to increase the use of balanced crystalloids and the reduction of normal saline. So I think this graph provides a great example of that, but you can see that over 55% of the time, over on the left-hand side is the fluid types that were prescribed, but normal saline being in gray, you can see that over 55% of the time, normal saline was prescribed over balanced crystalloids. That's because there's more internists usually in the hospital, but I'm not. But either way, you can see after the publication, and we all see this in clinical practice, you get a normalization between the two, but that's not good enough. And learning health systems actually provide a way to make system-based interventions, which show an increase in the balanced crystalloids and a reduction in normal saline, which is good, but not good enough. So needing a second, looking at things and how they're working through the virtuous cycle, you can see a more dramatic change there. But recognizing that's still not good enough, the investigators then used a smart app to educate providers to increase the adoption of balanced crystalloids in their patient population with the idea of reducing or improving outcomes. So now imagine how this could be applied in genomic medicine and intervention. So one of the things that clopidogrel is prescribed after a PTCA, but there's also other antiplatelet agents that are recommended in individuals that have a CYP2C19 allele loss of function. And one of the key things, which is interesting with the data, if you kind of go down the way that we're currently doing things, we know that a little over 40% of patients actually get clopidogrel, and we'd expect that to continue. But what does a learning health system do? It helps us improve the intervention, or to intervene and actually increase adoption, and which you hope to see over on the, with the blue line down there, you see a reduction in the amount of clopidogrel that's going to be prescribed on the first one, but going through this hypothetical example, there's a second intervention saying that's not enough, let's get it even lower. But the idea is, with, just like they did with the balanced crystalloid, is to use a learning health system to improve the adoption of recommendations. So one of the key things, I guess the way we think about it in terms of what are we trying to accomplish, but there's plenty of research ongoing and more institutes doing genomic research. They're generating that genomics is effective and also it's efficacious and it's also effective. And the important point is we're really not focused on that. We're really focused on the end here, which is really focused on doing qualitative and quantitative studies, designing implementation strategies, and testing those implementation strategies as a quality improvement as opposed to generating the evidence. So it's kind of, how, now you have this evidence, how do you implement it, and how do you do it effectively and monitor that, that it's being adopted? So we recognize that there's many gaps. I think using the example of clopidogrel, there's a black box warning in 2010. I think it's 2023. It's 13 years later, and we're still prescribing clopidogrel in those circumstances. But I think it gives, we think there's plenty of evidence-based genomic medicine interventions, whether it's monogenics with hereditary breast and ovarian cancer, time-sensitive genome sequencing, or pharmacogenomic testing. But there's also, we also recognize there's a gap in limited incorporation of genomics in learning health systems. We know there's plenty of learning health system kind of approaches in individuals using it, but we want to incorporate genomics. Need for improved exchange of genomic information across health systems. And then the last thing is there's really limited dissemination of genomic learning health system approaches, tools, and resources. So what is our objective? We're proposing that we actually develop a network of institutions with a track record of using a genomic learning health system type approach, including resource-limited communities. The intention is that they'll refine and develop these practices into implementation processes or resources, and then identify two to four network-wide implementation projects. And then they'll use those implementation projects to increase system-wide adoption, but also refine these resources for broader sharing, and then establish validated tools and resources to share for other institutions to adopt genomic learning health systems. The program structure is to fund the network over 5 years, issuing 2 RFAs, one for a single coordinating center, and then 4 to 6 clinical sites. The project plan would include in the first year really bringing them together, kind of seeing what genomic medicine things that they should consider for developing resources. But the idea was they'd take 2 to 4 of these and they would actually do intervention projects, again, refining those over those 2 to 4 years, and then the last year really developing and refining successful genomic learning health system strategies and resources that can be broadly shared. And the funding is $5.3 million over 5 years for a total of $26.2 million. And I did try to get through that a little quick because I know it's the end of the day. So thank you for your attention. But we are going to ask for all of council's input, but we did ask Dr. Jarvik and Dr. Kulo to start the discussion, and Dr. Kulo.
Thanks, Rob. So I didn't actually realize how much GLHS got attention in the strategic vision. So there's a lot of language in the strategic vision. There's a nice picture as well. So obviously, to get to this stage, it's gone through a lot of thinking and processes, so no concerns, and I think certainly worth moving ahead. I just had some comments about how we might increase the impact. First thing is, what's already in the NHGRI's portfolio and how this will synergize. Obviously, I think this program will take from lessons learned from eMERGE and other genomic medicine implementation projects. I was also curious whether there would be an opportunity for Anvil to evolve to where it can store clinical artifacts, and whether this would maybe synergize eventually with the GLHS. But that's a discussion maybe for the future. I thought that 5 or 3 or 4 sites probably wouldn't be enough for really good impact, and I was wondering whether we could partner with other institutions to maybe get it to 10 potentially. I'm sure many institutions are interested in LHS and might be interested in partnering, or whether this would be, I don't know whether a foundation, NIH effort as well that could contribute. The other comment I had was, having done a lot of genomic medicine implementation, is the inertia in the clinical systems. Whereas we as researchers, we have our protocol, we act on it, and we get results and publish. But this is a very different scenario when you're in the rough and tumble of clinical practice. And I think an advisory panel of, let's say, the various stakeholders would be really helpful, in addition to an ESP. So that could be vendors in particular, EHR vendors, IT, committees from different institutions, maybe in clinical practice committees, even payers. I think a panel of advisors drawn from those would really help for the LHS to navigate all these sometimes bumps that you encounter when you're trying to do genomic medicine implementation. And then evidence generation that would convince, specialty societies. Because in the end, as a cardiologist, for example, I think we look to AHA-ACC guidelines, and reaching those is the ultimate goal. So hopefully, we implement these in such a way that we generate the evidence to convince not only payers, but specialty societies. And sustainability, I think, would be key. I think you addressed that in the RFA. But I think, again, increasing the impact and generating, good evidence would help sustainability. And then lastly, I wanted to comment on the fact that, EHRs and learning will have a completely different meaning, I think, in 5 years' time. Learning health systems, my guess is, will be transformed in 5 years because of what we have seen in machine learning and computational advances in terms of large language models. I think the way we practice will be very different. And I would encourage maybe some language or some acknowledgement of that in the RFA so that, those innovations can be incorporated into the GLHS. So thank you.
Those are all very helpful. Thank you. Yeah.
I had a couple of questions. The first is, as you look at first of all, I just want to say I have a lot of enthusiasm for this, and I think it's a critical step in utilization of genomics in medicine, that it's better integrated in the EHR. But if you look around for who qualifies to apply for this, that they have some experience with a genomic learning healthcare system, what is that pool of applicants? I know you're only looking for 5, but what have you thought about that?
Well, I think there's plenty of learning health systems. In terms of that are doing genomics, there's limited publications of that. So, the process is going to be the same no matter what the intervention is. It's having the people there that have the willingness and also the interest in implementing genomic evidence into their clinical practice. So I think we'll be fine in terms of getting enough people that have LHS. The question is, will we have enough? And we're thinking there's maybe 15 out there that would possibly apply to this in terms of based on kind of our cursory review. We think there's plenty of sites that have LHSs. Whether they decide to make this genomics an important within their system is another question.
Yeah, so I read it as a little stronger requirement to have already implemented some genomic learning healthcare systems. So you might want, if you want a broader group of people applying, you might want to open that up a little. The second question I have is related to what conditions, because obviously I think, an obvious use case in what people are doing so far is mostly pharmacogenetics.
Yeah.
And it's kind of the easiest use case too. And the reason I think a lot of people do it is because you can do a little panel and then hit a lot of patients.
Right.
But a lot of the higher impact things, those patients are rarer. And so that makes it harder, I think, to have a competitive proposal. If you're not impacting as many patients, it's harder to collect data, have outcomes. And have you thought about how you're going to balance the portfolio of these projects? Like, could they end up being all pharmacogenetics? Is that what we want? Do we want to think about other kinds of use cases that aren't done so much?
Yeah, I think we'd be definitely open. I mean, as you know, I think the travesty is not every patient doesn't get IHC testing for colon cancer, and why hasn't that been adopted? Those are just one example of many, hereditary breast and ovarian, So I think we're going to leave it open to the investigators to come in and say what they think is best. And the idea is a little bit, we bring them all together to say, hey, this seems the most plausible to move forward based on the evidence. But I don't think we're going to restrict it. But I think you make a good point. I think we'd want them to take on several different genres, if you will, of different things, whether it's monogenic versus, something more, a little bit nuanced, like a, newborn high genome sequencing.
Yeah, and I wouldn't propose restricting the applications. I'm just thinking as you look to balance the program, in the end, it's going to be much easier to get a highly rated pharmacogenetics proposal.
Right.
I think you just have to think about where are we trying to get with this.
Right.
And, so that you may need to think about balance at that point, which is not appropriate at this point, yeah.
Yeah, no, definitely.
Okay, thanks.
Yeah, no, thank you.
So I just have a comment that through this is, first of all, I fully support this. I think that this is really great. And as I was watching the presentation, I'm wondering, I'm a little bit confused of, are you really looking for dissemination and implementation science in this? Or are you just looking to see if it could be implemented?
Well, they're almost, so a learning health system, implementation science is dovetails so well, it almost has to be part of it. Because it's that process of going through, identifying what's the evidence-based intervention, and then going through the cycle of implementing it. So it's definitely an implementation science, but it's within the context of a learning health system, which is, I hate to use it, but it's more of kind of a philosophy of the institution that we are going to be a learning health system. You really have to have everyone involved because it's changing the system. I did hear from one institution that they had to go through 37 different committees just to make one change like this. So the point of it is, I guess you have to have the learning health system. Is kind of, in my mind, I see it as kind of this umbrella of philosophy, leadership, champion, and then the implementation science is actually the operational part of it. How do you actually put it into practice? How do you monitor that? And then how do you adjust the system to be able to adopt it, if that makes sense?
And the outputs are a little bit different because part of it is, helping other systems move into a learning healthcare system also is, thinking about that. And the implementation dissemination scientists kind of say that they would study something slightly differently.
Yeah.
Nancy, go ahead.
Yeah, no, it was apparent at the NHGRI training meeting in Salt Lake City that this combination of words, genomic and learning healthcare system, sometimes it was a learning genomic healthcare system or a genomic learning healthcare system, was used for a lot of trainee posters and presentations and activities there, most of which were just trying to translate something. So it's genomic medicine, but not what you just described as genomics in a learning healthcare system. And I think not everybody really knows what the learning healthcare system is about. Certainly the places that do it know, and that's what you're looking for, so that may be fine. But I think the parts of this that are really interesting involve, what data you collect to learn more. Yeah. And Gail's point that the implementations we've already done, we already know some of the data that you need to collect and the ways you need to tweak those to increase uptake and the reasons it's hard to do in the healthcare system. And so it does seem that the emphasis ought to be on things we haven't done, don't know how to do, or that have failed
Yeah.
to date in implementation. And I think that's an interesting and harder question, to really to pull into the learning healthcare systems. But I love the idea too. I mean, I think it's hugely important, and we want to accelerate the learning process, right? We want to make this faster and easier to do, make it easier to disseminate, and bring more people into it. Be the change agent, as it were, for getting things translated, recognizing the inertia in the medical systems is high.
Yeah, and feedback is, that's what we like about the learning health system approach. There's that constant feedback. But, it is, as you know, aspirin now has changed a little bit in terms of how we prescribe it and recommend it. But to change the whole health system, to actually be able to get the health system to now use it more appropriately, as you know, there are certain ecosystems that just take a while to change.
It's great opportunity here, and complicated.
Yeah, complicated.
Other questions or comments?
Great. Thank you
No,
very
no,
much.
wait,
Oh.
don't leave just yet. Can I get a motion to approve the concept, please? Second. All in favor? Anyone opposed? Anyone wishing to, oh, Lisa, your hand is up.
Raise your hand to vote.
Oh, you're voting?
She's voting.
Okay,
I think she was voting.
all right. Now you can go, Rob.
Perfect. Thank you. Thank
Thanks,
you so
everyone.
much.
Xander, want to come forward, please?